And, I noted that the data and statistics, of course, can be cherry-picked. And so, I want to get a sense, people may be listening to this conversation and think, well, he found an epidemiologist who tends to agree with him. Is there a substantive debate within the epidemiologist community about what is going on here? What is the best way to proceed? And if folks like Pence and Trump and the various governors, saying that it's either behind us or it's not happening, or even if it is, it's more dangerous to not just open for business and learn to live with whatever may come. Is there a substantive debate among epidemiologists about how to proceed here? Are there voices like those we are hearing on Fox News telling us that, it's safer, it's better to just ultimately fling open the doors and hope for herd immunity to show up at some point?
Okay, so I don't have a short answer for this. You have to bear with me. Mm-hmm. I need to present you the context in order to answer this.
Okay.
I know everybody keeps saying that it's the testing, and that's why you're seeing these numbers. But I think what we are seeing is the number of hospitalizations. And when I talk about context, this virus is unprecedented in the combination of how easily transmissible it is, and in terms of the range of symptoms you have, which is from none at all to deadly, where you'll end up going into an ICU. At the same time, we also have a very highly susceptible population. Almost 95% of our population is still susceptible. Mm-hmm. So there is a potential for continued exponential growth in cases. We are still at least a year away from vaccine, no matter what people tell you. The only therapeutic that is currently available, which is in clinical trials, is remdesivir. And today we have dexamethasone. The paper is going to come out, but not enough. So what are our options? You mentioned herd immunity. Mm-hmm. When we talk about herd immunity, it took us 2 years and 3 waves infecting 500 million people, killing about 50 to 100 million people to reach herd immunity for the 1918 influenza, which we call the Spanish influenza, which is a misnomer, the 1918 influenza. But we are much better prepared now to manage the medical implications of the pandemic. But an uncontrolled strategy, if we assumed a 1% fatality rate, would still result in nearly 2 million deaths in the United States. And it's still unlikely that with that, we would reach the 60 to 70% herd immunity threshold that we would need. Mm-hmm. So I don't think this argument about herd immunity is going to work. So what's the next option? Virus containment? Well, the 2003-2004 SARS epidemic, the virus containment using epi measures such as isolation of the sick, quarantining of the contacts, and implementing social controls where we were limiting the damage, led to 8,000 SARS cases globally and about 750 deaths. But because of an uncoordinated and poorly managed COVID response that we are having right now, again, this option is no longer available to us. So what is left? Stay at home or shutdown orders? Now, when we think about that, a Nature article actually suggested shutdown orders prevented about 60 million novel corona case infections in the United States and 285 million corona cases in China. While this seems like a good investment, it depends on how you look at it. If we had used the period of the shutdown to put comprehensive testing and tracing protocols, like I said, in place, this investment would have paid off in a long run. But we failed to do that. So we only delayed the day of reckoning for us. So there is a lot of disagreement about the cost of delaying these infections. One of the economists from Virginia Tech and his colleagues, they calculated and they said the loss in U.S. GDP between March 19th and April 15th was roughly about $1.15 trillion. That's about 26% of GDP compared to the prior year. So when we think about it, benefits of stay-at-home order or their reinstitution, well, we're going to buy time. And we're going to buy time for developing the infrastructure to do a comprehensive testing and contact tracing, if we can put that in place. We can buy time for developing the vaccines and therapeutics so that we are not exposing our susceptibles. and we can preserve our healthcare capacity in order to maintain a reasonable standard of care for our patients. Those are the things we need to think about.
Mm-hmm. And I presume that is, as the question was generally, is there a debate among epidemiologists? Is there generally agreement among the group that those are our choices and that's what we have to deal with at this point? We basically have closed off all of the other options?
Well, the only thing we can think about at this point is, again, because of how heterogeneous the virus prevalence is in each of the communities. You have the hotspots. You can't have the same orders in those hotspots as we would have in other communities. Mm-hmm. So masks is something that all of us in public health are pushing for. As you continue to do everything else, maintaining physical distance, washing your hands, staying at home if you're sick, Masks are a lowest hanging fruit and one of the most economical interventions one can think about. And if all of us did it, we can dramatically bring down the number of infections.
Are there still no masking mandates in the state of Arizona?
Oh my God! You will not believe. I go out to do my grocery shopping once every 3 weeks, and when I went out, I felt like I was in the pre-COVID era. Oh. People just seemed like nothing had happened. People were sitting at the coffee shop, sitting outside in the tables. There was no concept of physical distancing. We were probably like one or two of us who had a mask on, and we looked like the outliers. So I think that sense of risk is not there at all here in the communities that I'm seeing.
That is absolutely terrifying in one sense. In another sense, I really appreciate you confirming this because I've been saying this for the past couple of weeks, that there are people out there sort of pretending this away. And that just seems to me insane and wrong and is going to make things worse, not better. So, to hear those same concerns from someone who actually knows what they're talking about is actually, ironically, a bit of a relief. How that I'm not insane, at least. How concerned should we be about outbreaks following the huge protests around the country after the police killing of George Floyd in Minneapolis? And sort of in a related question, would you advise against the president's rally set for Tulsa on Saturday?
The protests that are happening, I'm really sorry about all the killings that are happening, and it's a concern to all of us. We do feel for what is happening. At the same time, I think a lot of us would be concerned about the spike in cases, especially because when you're in protests and when you're shouting, the risk of transmission is much higher because of the aerosol infections.
Yeah.
So if you're not masking and you're in such close proximity and shouting at that high level, the risk of picking up an infection is going to be high. And this virus is nonpartisan. It doesn't care which party you belong to. It's going to come to you if you open the door. And that's what I keep telling people. It's a house guest. If you invite, it will come in. Mm. So try not to invite it into your house. Then that's how you can do is making sure that you don't go into a crowded environment. You protect yourself. So no, I don't think it's a good idea for us to be having 20,000 people in a closed door environment signing off their liability to say, okay, I'm not responsible if you get COVID, because there is going to be a very high risk of transmission there, and that I would call a super spreader event. When you have that kind of things happening, those are the places where spread is going to happen very quickly.
Is there any substantive difference between a large gathering like that, whether it's indoors versus outdoors?
If you have to do harm reduction, if you're absolutely going to do it, then yes, we would suggest you do it outdoors, because the likelihood that you will be in such a congested environment is much lower. And then in the outdoors, the likelihood of spread is also a tad bit lower than when you're in a closed-door setting like that.
Dr. Purnima Madhivana, and I've got just another question or two for you here. There was some potentially good news on Tuesday about an encouraging number of tests of a new steroid treatment for those critically ill with COVID-19. I don't know if you've had time to look at that test yet, but should that offer us any encouragement, or is it not unlike those preliminary reports we saw a few weeks back, on a new vaccine from Moderna a few weeks ago that made the stock market go crazy, but then proved to be more hype than actual hope?
I think you're talking about the dexamethasone, which is the steroid that is being used among hospitalized patients. The paper is not out yet, so we don't have much details about it. But yes, what they have found is it is able to reduce the number of corona deaths. Dexamethasone is a steroid that we've had all along, and we use it all over the world. It's anti-inflammatory. But what would be interesting for me is to see the data actually. Who got it and how were the samples. It's the same story as the hydroxychloroquine in the French study. I want to look at the paper first before I can really comment on it. But it's good news. People are talking about it. I'm curious. I want to read the paper first.
How ridiculously responsible of you, Doctor. Finally, I don't want to be too extreme here, but the Institute for Health Metrics and Evaluation at University of Washington, which has been very conservative in their prediction numbers, having needed to revise them up a number of times. Well, they did so again today to predict that we will see now more than 200,000 deaths in the U.S. by the beginning of October on our current trajectory. 200,000 deaths from the IHME's so far very conservative estimates. Given that I am not paid to keep the public safe, but even I can read charts and scientific data, it seems to me that some of the denialist public officials, talking about that governor in Oklahoma, even your governor in Arizona there, we see these numbers, we see these warnings. It seems to me that they are, in effect, signing death warrants akin to mass murder when we're talking about 200,000 deaths, mass murder of their own constituents, ultimately, by lying to them about infection rates and failing to mandate simple practices like wearing masks. Is that a too extreme way to look at this? Because I'm having trouble not doing so when I hear those statements from those governors and those public officials and so forth.
Well, I think, history is going to remember this, and, we'll have to confront with what we are doing right now. My biggest concern here in Arizona is Phoenix. We have almost 50% of the entire state of Arizona cases right here in Phoenix. But we don't have enough hospital beds for them. And are we going to come to a situation like in Italy where we have to decide who gets a ventilator and who's going to die? And we don't have to be in that situation. We are one of the richest countries in the world, and we should be able to take care of our weakest and the poorest. And if we don't do that, I don't know with what face we can go back to our constituents and say, vote for me again. In Arizona, we are even confronting the truth because they keep saying, our governor says we have enough hospital beds, but he is not telling us that when you say enough hospital beds, those are all over the state. It's not like you're going to airlift somebody who needs a ventilator in Phoenix to Yuma.
Yep.
So when you start looking at the geographical spread, we have a crisis situation right now in Phoenix. And if he is smart, he would close out the borders to Phoenix like yesterday. And that's not happening. This is just my personal opinion. So I'm not representing anybody. And the reason I say that is, for example, we have about 19,000 cases in Maricopa County, which is where Phoenix is. And the number of cases to date in the whole state of Arizona is about 36,000. So it's almost like half of those cases are in Maricopa, which is in Phoenix. Now, if we say roughly 10% of these cases are going to get hospitalized, that means our current average would be about 1,300 new cases each day would be assumed to result about 130 cases would need to be hospitalized. So we don't have that kind of bed capacity in Phoenix. The biggest challenge is if you have about 1,100 ICU beds and every day you're going to need about 130, you're going to max out in the next 1 week. And worse is staffing. How are you going to staff? You don't have enough personnel to staff. Even if you bring in all these extra ventilators and extra beds, you don't have enough personnel. That's the concern for me. And I don't think we are talking about it, about how hyper-local this whole situation is, and when they just generally say, oh, Arizona has enough testing, Arizona has enough hospital beds. But they need to be where you need it.
Yes. I'm concerned that same story is going on in a whole bunch of different states, not unlike Arizona, where you have these, clusters like in Tulsa. You're a breath of fresh air saying some of the stuff that I've been saying for now a long time. Glad to hear someone like you saying the exact same thing in many ways.
I guess you're just looking at the same data that we're looking at, and that's it. And we're looking at it the way you're supposed to look at it.
That's what I thought. That's what I hoped. Dr. Purnima Madhivana is an infectious disease epidemiologist and associate professor in health promotion sciences at the Mel and Enid Zuckerman College of Public Health at University of Arizona in Tucson, where she is the director of the Global Health Training Program. Dr. Madhivana, really appreciate your time with us today. Hope you won't mind if we bother you again in the future.
Thank you, Brad, for having me. I'm happy to come back and talk to you about what I know.
Thank you so much.